intertrochanteric fractures, they are like commonest fractures, around 50% around the hip are intertrochanteric fractures. They are common insufficiency fractures because of insufficient osteoid. They commonly occur in elderly osteoporotic females with comorbidities and mortalities as a result of complications and after effects. We classify IT fractures in stable and unstable type. In advanced classification, we say that it is type 1 and type 2 which are stable fractures, and type 3, 4, 5 are unstable fractures. AO classification, stables are A1 and unstable are A2 and A3. So what are these unstable fractures? Unstable fractures basically are comminuted fractures. They have sometimes reverse obliquity. They have loss of postomedial continuity because of comminution, lateral wall blowout, and sometimes subtrochanteric extension. You can take CT scan to understand this fracture geometry better. Management, initially we had extra medullary implants, then we came out with intramedullary implants. There was a lot of evolution for IT fractures. Those simple fractures, we do internal fixation, whatever you want to do. For stable fractures, we also do internal fixation. Then where is the question of this? For basically the question of debate is unstable fractures in elderly osteoporotic, which we also do internal fixation. Nowadays, we have bipolar hemiarthroplasty. The surgeons nowadays do one surgery. They want one surgery for one patient, only one surgery, so that patient should not get, because you are not sure about union because of elderly osteoporotic patients. So nowadays they are coming up, many surgeons do hemiarthroplasty, either cemented or cementless hemiarthroplasty, or they do total hip replacement. This was in way back, this article in 2005, where it showed that nail provides better, superior outcomes than hemiarthroplasty. Again, this article showing that comparison between intertrochanteric fracture in elderly with PFN and hemiarthroplasty. They had Harris hip scores initially were better in hemiarthroplasty, but after that, after 6 months, it diminished and even reversed at 12 months post-operatively. So this favors fixation for proximal osteoporotic intertrochanteric fractures. So how do you fix? Standard of care nowadays is PFN, gold standard I will say. Why? Because it is versatile, economical, and there is a lot of safety profile. What is the comparison between DHS, like extramedullary plate and intramedullary nail? In PFN, we have reduced liver arm and therefore decreasing the stress liver arm, and therefore there is implant failure is less in cases of PFN. What about this telescoping? There is less telescoping with PFN, and therefore there is varus collapse is less, and therefore shortening, and prevents medialization of shaft. So PFN can be applied to all type of fractures, whether it can be stable, unstable fractures. They are load sharing. Axis is closer to the center of gravity, and of course small incision, blood loss, and less failure rates. This is a meta-analysis in which they say PFN is a better choice than DHS. PFN, again, if you compare with arthroplasty, the Harris hip scores, blood loss, and operating time, it is better with fixation than with arthroplasty. The internal fixation, of course, preserves the native femur and gives chance to biology. So it's a God-given hip. Why you want to change it? And especially in patients with who doesn't have any only intertrochanteric fractures, why you want to do replacement? The advantages being blood loss, which is minimal, and therefore no need of transfusion. There is lower 1-year mortality. Functional outcome with fixation, PFN is better, because after union patient can sit square, cross leg. Then there is long-term solution. You don't need to revise it once the fixation and union has occurred. Hospital costs are less because of shorter surgery time. It is a simple procedure, natural healing. Duration is definitely 15 minutes to 45 minutes, surgeon can finish up with the case. And you keep your options open. If anything fails or there is complication, you can do something for that. So a fixation well done can last the patient a lifetime. There is always a flip side or negative sides from fixation. There may be Z effect or reverse Z effect, prolonged hospital day or delayed mobilization because of osteoporotic fractures. Whether it is definitely it was due to implant or it was due to surgeon, there is a big question mark. So there is this paper says there is a PFN, there is a complication of around 20%. Out of this, 10% was due to the lateral migration of helical blade. Remaining 10% was due to the quality of calcium reduction. So your reduction, if it is good, your failure rate will be much lower. This success depends largely on the technique, reduction. If you achieve a good reduction and do PFN, that is, results are definitely good. Especially, you should operate as early as possible within 2 to 3 weeks. After that, again, the results will be guarded. Correct entry point, tip apex distance should be less than or equal to 25 millimeters, as you all know. Correct screw placement, positive peak in the AP and lateral view. Now there are advances which have come for nailing. You also know PFN A2, this single bolt system, single helical blade, striker, gamma 3 nail, Triton inter 10 nail. You can reinforce with a cement. You can augment the nail with a wire, or you can do a lateral buttress plate. So food for thought is you better will treat this when you have a lot of options like revision nailing, revision fixation with angle blade plate, or finally definitely I will not say you cannot do replacement. Yes, you can do. Or this in this patient, like where the options are very limited, like revision arthroplasty. If it fails, re-revision, again re-revision, and goes on. So I conclude that fixation should always be given a chance along with medical management of osteoporosis to provide best functional outcome to patient for the remaining lifespan. Again, osteoporosis patient is there, you can immediately start teriparatide injections, and you have multiple, you can start immediately on day 1 or day 2 also. So there is a, like in search for short-term gains, one often ends up with long-term pains. Basically, if you are doing angioplasty, yeah, patient will be walking immediately, he can wait there. But again, the results later on is not very good. I thank you all for your kind attention.